tell you, I'm familiar with this part of the state because when I was in college in Tennessee, my boyfriend lived in Rome. And so we came down here all the time. And that's how I found out about this part of the state. Years later, when I went to open a center up here, I was thrilled because I got to meet old friends again and to interview and find people who could help us build an AHEC for this region. So this region has a special place in my heart. I want to talk to you about healthcare education. Specifically, I'm going to talk about some of the physician issues and then also some of the teaching issues across the board in healthcare professions. So I'm going to start with shortages. The reason that there's so much attention on healthcare right now is because we don't have enough people. You can give people financial access, but if they have no one to go to, what do? How many counties don't have a pharmacist? 5. Now, can you imagine living in a county that doesn't have any kind of pharmacy? It's pretty amazing. Close to where I live in Taliaferro County, some people call it Taliaferro, but it's Taliaferro, they have no pharmacists. They have very little health care. They have a community health center that's open a couple of days a week. But if you get a prescription, what do? The community is so poor and so old that almost 100% have insurance of some sort. Well, what do? There is a woman who lives in the county who works at a pharmacy in Lincolnton. And if you can get the prescription called into Lincolnton and you can get her the cash, she'll pick up your prescription and bring it home and you have to get to her house to pick it up. That's what they do. Now, can you imagine that where you live? There are some serious problems in the state. Shortages are about 3 different things. One is, does the workforce mirror the population? And if it doesn't, then we have a shortage in diversity. The distribution, where are the providers? If we just keep churning them out and they go to the same place, we still have shortages. And then what kind of providers we have. How many dermatologists do we actually need? And how many zits are there in the state? Right? But we churn out those dermatologists. Do we churn out the primary care people? No. And yet, what do we need? Primary care. Why do shortages matter? There are studies that show that patients, when they have the option, choose a provider who looks like them or has similar backgrounds to them. Why is that true? I'm going to keep asking y'all questions, so you might as well start answering. I don't like to do this by myself.
More comfortable.
More comfortable? Trust? Is anybody here not sitting with somebody from their own organization if someone from their organization is here? See? That's about 7 of you out of this whole group. We sit where we're comfortable, right? We choose providers that we're comfortable with. There's also some really startling research that's coming out saying that there's an impact on the quality of the healthcare and the outcomes. For example, as we've gotten more Black female physicians, you can track the same decrease in breast cancer and the rates of late-stage breast cancer. That's pretty powerful. It's very powerful. So a diversified and distributed workforce has a lot of benefits. You can read, so I'm not going to list them all. But you know, the increased satisfaction is huge. The greater health care, people going to people they feel comfortable with instead of just saying no. Have any of you ever gone for a health care visit and felt so demoralized when you left that you swore you'd never go back? Yeah. And it's unfortunate because we're the one teaching them. I had a gynecologist one time, and I swear to you, he would never have recognized me in a grocery store. I don't think he knew I had blue eyes. I felt just like I was one body part anytime I was around him, and I hated it. And so then I chose to start going to a woman. And now she's one of my best friends. In fact, she delivered my 2 children, and I was the last delivery she did before she delivered her own 2. So we have kids who are like days apart. In fact, the second one wasn't sure she's going to be able to catch him. She was so far away with her belly. The understanding of medical research. You know, if we have more people of all kinds of backgrounds in medicine, they're going to be interested in different things, right? So our research is different. The biggest example of this right now is in cardiac issues. All these studies, but they didn't study women. And now that they are, they're finding out that we have different symptoms and we respond to different medications. Huge issue. Now I have another little pet peeve. I keep thinking as we get more women in research, someone will fix menopause. You know, we know all about Viagra. We can send men to moon, but we can't stop sweating. How many of you know what I mean? Okay. Personal summers is what my grandmother said. I can't believe no one's figured this out yet. But hopefully as more women are in the workforce, this is going to become more of a priority. So I'm going to look at Georgia's demographics to see how we look compared, the workforce compared to the population. In the general population, oh, I have a little thing. Georgia has been a fast-growing state. And in fact, our physician increase has been at a higher level than the state's population growth. So that's a good thing, right? Except in primary care, didn't keep up. And in specialty care, look at that, 35.9% growth. So we had the right kind of growth rate going to fix the shortage, but not the right kind of people. Looking at the race of Georgia and then the medical workforce. We'll flip that back and forth for you. Are we mirroring the population? No. Look at gender. In the state, we're about 51% female, 49% male. In the workforce, big difference. About 80% male, 20% female. That is changing. But one of the big pushes has been to get males into the non-physician workforce and allied health and nursing, PA programs. So we're focused so much on getting men into those disciplines that it affects that thing negatively. Gender by specialty. Pediatricians have the highest percentage of female physicians. That kind of shocked me. I don't know about y'all, but that kind of shocked me. It's the only specialty where females constitute 50% of the workforce. Surgical specialties, on the other hand, only about 8.3% are females in general surgery. In education, I actually thought this was hard to believe. I double-checked this in many sources. But about 27% of our residents aged 25 plus over a 5-year period have a bachelor's or higher degree. For our population, according to that number, we have people moving into post-secondary. Is that enough? Do you think? Of people going into post-secondary education in our population? No. No, it's not. I live in Richmond County, and there's this wonderful website you can go to, the Governor's Office of Student Achievement. And it'll tell you by county, and if you dig deep enough, by school within each county, what percentage of the students qualify for HOPE, what percentage go on to post-secondary enrollment. It is a scary website. Richmond County, second largest city in the state, and less than 23% of our high school seniors qualify for HOPE. That's a problem. We have to be concerned about that part of the pipeline. We have an aging workforce, and for the physicians in the room, I'm not trying to insult you or anything, so just understand this is data, not personal. But the physician workforce is aging. About 31% of the physician workforce was 55 or older in 2008. The population at large was about 23%, 55 and older. So the physician workforce is older than the regular workforce. If you look at it by the primary care specialist, about 38% were over 55. And that was for general surgery, and then primary care family medicine was 33%. Now, I'm going to give you a little bit of distribution issues. In rural Georgia, what percentage of the physicians are 55 and older? How much? 100%. They're all old. No. It's about 65%. Now, what happens in 10 years in rural Georgia right now? If you think there's a shortage now, it'll be impossible in 10 years when all those people start retiring if we don't do things different. Pediatricians have the youngest cohort of physicians, so they're in better shape than most. Now, I'm going to show you some geography things. These are maps. I'm going to go through them quickly. What I want you to do is watch the colors for patterns, okay? 52% of all Georgia physicians are located in 5 primary care service areas. Those service areas represent 38% of the population. Keep that in mind. That's our dental health professional shortage areas, okay? Basically, if you're white, you haven't applied for a designation because we are short on dentists in this state. If you are blue, or that's supposed to be purple, you have a low-income population group for dental shortages. Green means it's just the whole county, and red means other census tract cohorts led to the designation, and it's the worst. So in, whoops, your part of the state, you got some dental issues. Primary care shortage area for the HIPSA designations. Primary health profession shortage area scores 14 or greater. That means you're doing actually a little better up here than certainly down here. That means you really are having a bad problem, like you're fixing to collapse. Medically underserved areas. Mental health professional shortage areas. This part of the state has the strongest need for mental health. Did y'all know that? Why is that? It's not because you're all crazy. What is it? Raising children. No. What it is mostly is that you're the fastest growing part of the state. So when you have all those new people coming in, a lot of which are elderly, who need more health care, you have to have more social workers, you have to have more psychiatrists, more psychologists, a lot of the discharge planning that's required by Medicare and in the hospitals. You have a huge issue in this part of the state. So looking at our specialties in the physician workforce. Primary care service areas, are y'all familiar with that designation, how that's done? There are 96 designated in the state, and the way that they arrive at the boundaries of those is based on how people commute for health care. So if you're in Floyd County, and what's the county right north of y'all? All right, let's say Chattooga. Let's say 50% of the people from Chattooga come to Floyd, then they're going to be in that primary care service area. So in family physicians, I'm going to talk about the primary care ones. We actually have a better scenario than we had just a few years ago, in that there are 74 of the 96 that have an adequate number. But the distribution of family physicians is getting worse. Internal medicine, there were 3 PCSAs that had no internal medicine physicians. That's 5 counties. There are 55 that have an adequate number of internal medicine, but 33 have a deficit. Pediatricians, 22 PCSAs that did not have a pediatrician. That means there's 25 counties in this state that do not have a pediatrician. If you look at the top 4 PCSAs, they're in the Atlanta area. Pediatricians want to be there. You got CHOA, so that's one reason. The second biggest area is Augusta because we have the other large children's hospital. But 55 of the PCSAs are in deficit. Now, these are kids that aren't getting health care. OBGYNs, 28 PCAs had no OBGYN. That's about 29.2% of the state's PCAs. 34 counties without an OBGYN. 34. So tell me, is there any correlation to the fact that we lead in low birth weight babies? That we're in the bottom on infant mortality? That we blow other states out of the water on a lot of our statistics in this area? People don't have access. 34 counties. Now that's better than it was. At one point about 10 years ago, it was 92 counties. But this is a serious, serious problem. General surgery. 22 primary care service areas with no general surgeons. That's 25 counties. And the top ones are, of course, in metropolitan statistical areas. That's where they group. What is one of the problems with general surgery in rural areas? Actually, generally, it's the surgeons who keep the hospitals open. But what do you have to have a general surgeon? Nurses, surgical techs, anesthesiologists. And so it's a combined shortage there. More than 1/3 of the physician workforce in Georgia does not take new Medicaid patients. Doesn't bode well for the ACA, does it? So let's look at what those shortages look like nationally and in Georgia. According to the American College of Physicians, we know that systems dominated by primary care have better outcomes at lower cost. Yet we have a severe shortage of primary care physicians. They estimated 44,000 to 46,000 physicians, new ones, are needed by 2025. That does not take into account what will be needed to deal with the additional 32 million people who will be covered by ACA. That 44, 46 is with no changes. That's how short we are. The General Accounting Office from Congress says that we have ample research that a reliance on specialty care services at the expense of primary care is less efficient. HRSA estimates that by 2020, we have a need for 337,000 primary care physicians. We have a supply of 271,000 with a 65,900 shortage. Again, not including ACA. For the federally qualified health centers, which are huge in the ACA, in Georgia, we need about 1,400 primary care providers, about 2/3 of which are physicians, by 2015 to meet the need. 2015. How long is the physician pipeline? Minimum of 12. You go 4 years to get your undergraduate degree, 4 years of medical school, and about 4 years of residency. So if we start something right now, are we going to touch that? No. No. What we have to do is leverage who's already in the pipeline. But also we need to look at more roles for PAs, nurse practitioners in primary care. We rank 9th in the in population for the country, but 39th in the total physicians per 100,000 population. Basically, that says we suck. One of the ways we need to address this is through interdisciplinary training. So how many of you teach interdisciplinary? How many of you have read up on it and would like to try it? How many of you know what it is? Okay. Well, this may bore you to death. But this is something I'm really big on, and that is I work with the National Parkinson's Foundation on training interdisciplinary teams across the country. And one of the things that we find is that there's better patient outcomes, better professional satisfaction, and lower cost as you look at it down the road. So this is something that Canada, New Zealand, a lot of other countries have jumped on. In fact, they've even changed their education systems, as well as their reimbursement. You can work as an interdisciplinary team. Other options are independent medical management, the traditional model. the multidisciplinary, where you have people of lots of professions co-located but not communicating. Consultative is that's when you bring in people as needed or as you think they're needed. One of the things I did with a group of about 100 different providers is had them provide descriptions, educational background, and scope for all the other professions. And then we told them the truth, and they were shocked. So if you're using the consultative, you have to know what other people do. And right now there's so many turf wars going on that people aren't really aware of that. So some of the benefits for the patient in interdisciplinary care, you're treated as a whole person and not a body part. It increases the coordination of services. It empowers patients to be active in their own care, use time more efficiently, better patient outcomes. Very much like what we call patient-centered care, right? For the healthcare professional, it increases health satisfaction. It facilitates a shift in emphasis from acute care to long-term preventive care, enables the practitioner to learn new skills and approaches, encourages innovation, and allows providers to focus on individual areas of expertise. We are now finding that facilities and programs that operate in an interdisciplinary manner have a much lower turnover rate. People like it. For educators and students, it offers multiple healthcare approaches to study, fosters appreciation and understanding of other disciplines, models strategies for future practice, promotes student participation, and challenges the norms and values of each discipline. I just provided a whole training session on this with our house staff, about 125 residents, and I was asking them to tell me in their entire education, had they ever had classes with another health profession? If they'd ever had case management or a case to work on, if they'd ever been exposed to the other professions in the education pipeline. And out of that whole room, 2 people have had that experience. Now, they graduate and they go to practice. How do they know what they're hiring? How do they know how to maximize people's resources and skills if we don't teach them in the educational process about the other professions? I believe that a lot of the issues between the physicians and the nurse practitioners politically would not have arisen if we had been training them interdisciplinary, if there was an understanding. So some of that can be fixed in the education system and needs to be fixed. For the healthcare delivery system, holds potential for more efficient delivery of care, maximizes resources, decreases burden on acute care facilities as a result of increased preventive care, and facilitates continuous quality improvement efforts. Benefits and advantages of learning. Client-centered goals allow for the statement and formulation of common objectives, increasing team motivation, and enabling the evaluation of outcomes. One of the core components of interdisciplinary care is you evaluate what's happening from the patient perspective, from the professional perspective, and from the clinical outcomes. It's a healthcare system that supports effective teamwork, can improve the quality of patient care, enhance patient safety, and reduce workload issues that cause burnout among healthcare professionals. One of the things that they studied is how often a patient gives their history. Now think about someone with asthma who might be going to 4 different doctors and clinics, and they give that history 4 times at the same place. What does that patient think? What would you think? These people are idiots. They're next door and they can't use each other's stuff. Plus it takes them all those hours, many of which they have to pay for out of their own pocket. Improved teamwork and collaborative care have been shown to improve performance in many aspects of the healthcare system, including primary health care and public health. This is not just for chronic disease. It's really working in other segments now. There have been studies on improving patient safety, and they have found that team training and decision aids, such as the checklists and communication protocols, can improve team process and reduce adverse events. And they gave you lots of citations on these. I hope you can read them on your slides, because there's some really good studies out there right now. One of which is Peace Health. And the reason I'm giving you this is to try to incentivize you to think about this in your teaching. They are an interdisciplinary hospital-based outpatient clinic staffed by a team of geriatricians, nurse practitioners, nurses, a social work coordinator, dietitian, pharmacist, and other support staff. They provide primary care, comprehensive geriatric assessments, diagnostic and therapeutic services, and care planning coordination. Their target population is seniors, most with one or more chronic health conditions, and the study was conducted over 30 months. So this is a pretty intensive, weighty study. And it compared Peace Health patients with similar patients in 2 primary care practices. What they found was that the Peace Health patients maintained a better quality of life, improved patient outcomes, and reduced cost. Very specific. The staff satisfaction rates at Peace Health were well above those at the comparable primary care providers, 72% versus 60%. Peace Health patients experienced fewer falls compared to the comparable primary care patients' practices. The depression scores were lower, or I guess rather improved for Peace Health, while the ones at the other sites were worsened over this 30 months. Peace Health patients were significantly more likely to get pneumonia vaccines over the comparable practices. Patients at Peace Health were prescribed an average of 3.75 medications over the 30 months. Patients at the other practices were prescribed between 4.15 and 4.3 medications over the same period, even though the Peace Health patients had more chronic conditions and were sicker. Average Medicare inpatient charges per patient at Peace Health were $1,556. At the comparable practices, they averaged $2,437 per patient. Think about that when you add that up. How many patients? Over 3 years, Peace Health patients' overall charges averaged $5,690. Patients at the other practices averaged $7,900. That's a very significant difference. And it was all about teamwork. Because as an interdisciplinary practice, you're talking to each other, you're observing things, and you know when you need to pass things on, and you know when you need to get innovative. So how do we fix some of these disparities in the state of Georgia? I think one thing is we change our education process. We really need to look at how we're training professionals, because if we want them to act in a cohesive fashion, they need to do that in their education process. For the physicians, there's tons to be done. And I think of that as a visual to-do list. Now, are you going to remove everything at once? No. But we have to start taking steps, right? 2015, that's not even 2 full years from now, right? Well, it is, but 3 years. We're going to be in such trouble. So we need to start picking off those clothespins. One of the things is we need a plan. Now, in the AHEC system, we have committed to holding a primary care medical shortages summit every year. It's the 3rd Thursday of May. If you want to come, let me know. We really have chosen to focus on the physician piece first, acknowledging it's not the only piece. But you can't eat a bear at one time. You have to do one bite, right? You know, we're eating a bear. We need a plan. Part of that plan needs to acknowledge that physicians won't fix it all. We need a coordinated statewide messaging campaign. People don't know what primary care is. They really don't get it. And if they do get it, they really don't think it sounds exciting. So we got to change all that. Now, just as an aside, we consider dentistry part of primary care in the AHEC system because the data on oral health is so compelling about how it affects general health. But also, we have all these residency programs in Georgia for physicians, right? And we're trying to get a whole bunch of new money to open more. What percentage of Georgia medical school graduates go to a Georgia residency program? Anybody know? 23%. We've become the largest exporter of medical students in the country. Why is that significant? Data show that physicians tend to practice within 60 miles of where they do their training. So we need to train them here. So we got to figure that out and how to make our residency programs more competitive with our own students. And you know, I used to think that it's terrible to have to bribe people. I always thought people should do the right thing for the right reasons. Then I had kids, and I understand that bribery is very important. So we got to do that. We need 400 new residency slots in Georgia. Even though we're not filling what we have with Georgia students, we still need more residency slots. Because right now we are graduating more medical students than we can train in GME. There's a huge shortage of GME slots. GME is graduate medical education. That's residency programs. Huge shortage across the country. Most of them are located in the Northeast because they were allocated by population in the 80s. What's happened since then? Everyone's leaving the Northeast. They're all coming south, but the residency slots stay in the Northeast. So we have a huge campaign going to open 400 new residency slots. Two issues. One is that we want them to be primary care. Some of the hospitals don't. Why? Some of the other residency programs bring in more income. $1.2 million was appropriated last year. How much is it going to cost to do 400? $25 to $26 million. So even though 1.2 plus 2.08 is moving in the right direction, it's too slow. They got to ratchet this up. We need tax credit for primary care community-based faculty. Why is that? As we've expanded medical schools, we've expanded PA programs, we've expanded nurse practitioner programs, we need more community-based sites. Now, some people want to pay them to take their students. And in fact, Florida State University has decided to pay Georgia physicians in South Georgia to take their students. They don't pay the physicians in Florida to take their students. They know they're poaching. We can't do anything about it. The offshore medical schools will pay to bring in students who are doing their third-year rotations from the Caribbean and other places. If we in Georgia begin the process of paying sites, what's going to happen? This is crucial to all of you. What's going to happen if the medical schools start paying for sites? First of all, it's a bidding war, okay? Who else needs to use those very same sites? And can they afford to pay? So the collateral damage of medical schools paying those sites is that the PA and nurse practitioner programs are going to be crippled. Because what physician is going to take your students if they can get paid for a medical student, right? It's a huge issue for the allied health, the nursing, the non-physician. So what we're saying is we want to be able to give tax credits for primary care. Now, in the presentation I'm doing, I'm talking about the third and fourth year medical students in the primary care clerkships, because I'm usually giving this presentation to medical groups. The big thing is going to be students in primary care sites. So my goal is the nurse practitioners and PA will be included in this. So a physician, rather than getting $500 to take a student for 4 to 6 weeks, I'm making up numbers, which after taxes would take them maybe to Chili's, right? Let's give them a $1,500 tax credit with a max on how many you can have for the year. That means more to them. If they end the year with a $10,000 or $15,000 tax credit, that means a whole lot more than 5 or 6 chili dinners. So we need to think about creative things like that. That's not money out of our pocket, but it recognizes those physicians and people taking these students. We need revolving funds for community-based programs who are looking at creating residencies. We have several in this community up here who are looking at this. but you have to have money to get the program established before you can start getting reimbursement from Medicare. It's about 3 to 5 years that you have to fund yourself. We need provisional service cancelable loans. In medical school specifically, when they go into residency for that 4-year period, they're paying their loans back, but they can't get loan forgiveness. So what we're saying in primary care is let's begin loan forgiveness in year 1 if they graduated from a Georgia medical school and they are willing to commit to staying in that region year for year. That would be huge because medical students worry about debt. And then increasing the post-residency primary care loan forgiveness programs with service commitments to the National Health Service Corps levels and those in contiguous states. You know, right now, the Corps pays $60,000 the first year in loan forgiveness, and then $30,000 each subsequent year. We're paying $20,000. We've got to be competitive, and those scholarships, as you all know, are for other disciplines as well as medicine. Pathways to Medicine is a very specific program in rural Georgia where we get a whole bunch of students. They come for 6 weeks. We indoctrinate them, we train them, they do research, they present posters, and about 86% are now in medical school. And these are rural, underserved, disadvantaged kids. This is how we're looking at strategies and communicating the tactics and stuff. That's just a format. These are the baseline data because what we have committed to is every year we'll issue a report and say, has anything changed? And if nothing's changing, we're not doing the right things, right? So these are some of the baseline things we're looking at. And this is sort of our mantra. There are so many things that need to be done. But if we wait till we can do all of them simultaneously, we will fail. We've got to do each piece that we can and move it forward, always keeping in mind the full quilt. And this is how you contact me. You have an idea, you want to come to the summit, you want to expand or change my knowledge about something, I am wide open. And so I'd appreciate any conversations, dialogues, whatever, that we can have. And I think that communities like this, programs like this, can start modeling the changes we need to see across the state.